Good afternoon, everybody. I think it's noon, so we should start. We've got a full program this afternoon. A big thank you to those who have joined us in person. It's great to have a real live audience. I have to say that the last time I hosted a silent meeting about a new infectious bug was in February 2020, and this room was absolutely packed, and it was on this new virus called coronavirus that didn't have a name yet. So I'm a little bit having trepidation about hosting another meeting about an emerging or re-emerging infectious disease, but it gives me great pleasure today. I initially asked Mark Mendelsohn, who's joined us online, to give this talk, and he said, no, you must ask Professor Blumberg. So I thought, well, then it'll have to be online because she's in Joburg. But I contacted her and she said, no, I'd love to come to Cape Town. I'll come to Cape Town. And here she is. And not only did she do that, she has also invited Dr. Johan Hugo, who is the Senior Clinical Advisor at Hannover, to talk to us about communication about monkeypox. So we're going to start off with Prof. Blumberg, who I think needs no introduction, but from NICD, to give us a background around monkeypox and the public health response, and then move on to Johan to talk a little bit about communication, particularly in the MSM community. Thanks so much. Over to you.
Good afternoon, everybody here, and afternoon, everybody online. It's really a great pleasure to be here. I really needed some sea and mountain magic, and that was one of the reasons that I was easily persuaded. But it's really a pleasure to be here. Worked with Marianne. I met her, in fact, way back in 2020, when we were looking at the risk of coronavirus in the emerging ones in HIV, and did some really interesting and important work together. But no sooner had we kind of started to wave goodbye to COVID when a slightly different outbreak around monkeypox has emerged. So what I want to do today is to look at some of the background to monkeypox and what's been happening over many years in Africa, then move to the more current outbreak in Europe and other parts of the world, look at some responses to cases, but I'm not going to focus on clinical management. There is a webinar tonight, which is very clinical and hosted by infectious diseases. We'll look at some of the public health responses that have been initiated, and then examine some issues around vaccines, equity and access, and other issues around communications, and then I'm going to hand over to Johan. Thank you very much for joining us today. So in July, at the second meeting of the Emergency Committee convened through the International Health Regulations, it was decided to declare the unprecedented global outbreak of monkeypox a public health emergency of international concern. So this is the highest alert before declaring the outbreak a pandemic. There are certain criteria that one uses to declare something a feak or a fake. To be honest, they're not so difficult to satisfy and to tick the boxes. Unusual or unexpected event. This was a growing outbreak of monkeypox in a very different population, spreading quite rapidly. So the second criteria was ticked quite quickly, and really requiring a coordinated response, new research, and access to more resources. The committee was not unanimous in their decision. I think the feeling was declaring another feak on the back of COVID and presenting this to an exhausted community, especially a donor and research community, may not garner all the responses that were required. It may also stigmatize and put a focus on a group that, I think had already been experienced HIV and other outbreaks. But I think Dr. Tedros, the Director General, felt it was warranted. We needed to respond early and aggressively and try and prevent further transmission and nip the nip it in the bud, so to speak, before pandemic was reached. So this was despite the feeling that monkeypox has high morbidity in some populations, but at that stage a very low mortality. There were actually no deaths in any people affected in Europe, but that's not quite the case in Africa. And that globally, in many parts of the world, the risk assessment was low, especially the Western Pacific areas, probably overall moderate at global level, but in the European region, at the time of this meeting, it was really considered high. And I think at the moment, in fact, the United States has the highest number and the most rapidly growing outbreak. So just a step back in monkeypox, the name is a bit of a misnomer. So in 1958, monkeypox, which is part of a big group of viruses called the orthopox viruses, smallpox is perhaps the best known one, was confirmed in imported laboratory monkeys in Copenhagen and Denmark, and it was given the name monkeypox. There's been a lot of controversy about the name monkeypox, stigmatizing monkeys that are not the reservoir, and there's a lot of discussions about renaming the virus, and those are ongoing, and I'm sure there'll be some movement there. The cases in Africa are in quite remote areas, close to tropical rainforests, and most of them are in countries in Central Africa and also in West Africa. But in fact, the disease is expanding more into slightly more urbanized areas and perhaps some near geographical areas. The outbreak, the animal reservoir is unknown. It's probably some sort of rodent, but a very large number of animals get infected secondarily from this unknown reservoir, and those are probably the source, the original source for humans. But in fact, how humans get it is not known. So it's seen in people of all ages, probably those who are exposed to infected animals, non-human primates, squirrels, a variety of rodents, during hunting, for food or for sale, bushmeat, etc. So it's a very, very different epidemiology. Transmission is then possibly through infected people, maybe through fomites, but is not absolutely clear. Something's happened. Where's some people? Hang on a sec. We are. Oh, there we go. So there are two different clades. There's the Central African one, which has a much higher mortality, up to about 10%. There's the West African one, which is around 1%. And the current outbreak is related most closely, but not identically to the West African one. Severe disease is seen. The extent is not absolutely known, particularly in children, pregnant women, and probably those with some immune suppression. Secondary infection is not uncommon of the lesions, or more generally, myocarditis has been reported and encephalitis is reported. And I think what is concerning now is that the number of cases, remember there are no diagnostics easily accessible. Interventions for managing ill patients are very limited. And getting a diagnosis in some remote community in a forest is not easy and probably doesn't happen, but the lesions are fairly recognizable, and it's mostly a clinical diagnosis. So the number of cases is not absolutely known. It's hundreds, it's thousands, it's difficult to put a number to it. But what is being reported is that there's an increase in the geographical areas, particularly in Nigeria, increase in numbers, and it's being put down to waning immunity from smallpox vaccine. And what is absolutely critical is there is no access to vaccines at all now. We'll talk about smallpox vaccine and cross protection, and there are no specific therapeutics and very limited healthcare. So that's key when one looks at equity and access to some of the countermeasures. So what happened in 2022? So from time to time, we've seen outbreaks of smallpox monkeypox, sorry, in Western countries. There was a big outbreak in 2000, and I think it was 2004 in America, related to imported animals from Africa for sale as pets. We can talk about that story another time, but I think there were 71 cases of monkeypox related to people buying pets. There's a big trade in wild animals from Africa to all over the world, and they imported rodents that were housed with prairie dogs. Prairie dogs are actually very cute rodents, and they get sold to children. And this was a multi-state outbreak, but no deaths. There've been from time to time travel-related cases, people going travel mostly to Nigeria, coming back to various parts of the world, but really a handful of cases. So early in May, there was a case reported in the UK, somebody who had traveled to Nigeria. The UK Health Protection Agency had followed it up. Yeah, I think that all settled. But shortly after that, there were a number of cases that were confirmed without links to this case or travel to Africa. And I think they're still working on some of the epidemiology. And then, you know, the world started to open up because of COVID restrictions being removed. People started to get together. There were a whole lot of social events. There were a number of Pride events. And by 10th of August 2022, there were 32,000 cases suspected or confirmed in 84 countries around the world. And the biggest increase has been in the United States over the last few weeks, so much so that they declared monkeypox a health emergency, first in a couple of states and now more generally in the United States, really to try and improve the response and gain access to more countermeasures. So the majority of them are male. Many of the first cases had links to Pride events, and it would seem as though spread has been perpetuated through amplified through, I think, some social and sexual networks related initially to Pride events and then much more locally. To date, there have been 4 deaths. I think 2 of the patients have had encephalitis related to monkeypox. One person had an underlying hematological problem, and I'm not sure about the other. The 350 healthcare workers that have been identified probably acquired disease in the community and not related to monkeypox caring for patients. I think the one thing that COVID, you know, is still a little bit of a legacy, it's still remaining, is better infection prevention and control. So I think the use of gloves, masks is much more in place. There's a recent article, a very detailed article looking at 43 sites in 43 countries and clinical epidemiological features of the infections, and highlighting that the 98% were men who had sex with men or bisexual, 41% were HIV positive, a number of them had other sexually transmitted infections, overall less than 40. Sexual activity with close contact was the most likely route. We'll come back to, is it a sexually transmitted disease? That is a very different discussion. And slightly atypical presentation of the disease. Some had a prodrome before, some had it only after the lesions came out. Incubation periods were very variable. And in distinction to the cases in the endemic areas, although many had a rash, often there was only 1 or 2 skin lesions. Anogenital lesions in the mouth were very common, but anogenital lesions were particularly an issue, and often associated with very severe pain, requiring hospitalization and intensive pain management. So what about South Africa? We've had 3 laboratory confirmed cases to date. I think it's probably an underestimate. It's for many people a mild disease. There's a lot of, I think, discussion between groups who may be affected, knowing that most will get better and they don't need to seek care. risk, stigmatization, and aren't presenting for diagnosis. Access to diagnostics is limited everywhere, but we have some. So we've sequenced them. It's a West African clade, slightly different. I think there's a bit of diversion from the West African cases. We have testing at the NICD, and now a number of private labs have started testing. I think that's a good thing. So access to diagnostics is a major problem in most countries, even the West. We've had a lot of requests. I think there's 6 or 7 or 8 or 10 a day. They are 99% other. And, we were asked, well, if you need to test everybody so that you don't miss any, and you can initiate the right public health response and get a good idea of what the size of the problem is and motivate for vaccines. The problem is, as soon as you say monkeypox or query monkeypox to a patient or a parent, there's huge fear. There is stigmatization. Nobody treats the underlying disease, which may need treatment. And like we had with Ebola, they get sort of pushed aside until the result comes back. So 99%, I would say, are chickenpox. And 2 months ago, chickenpox was very easy for people to diagnose. Now people see a vesicle, they go, oh, could this be monkeypox? And nothing else gets done. So we're not doing them all. We are reviewing them very carefully. We don't want to miss cases, but I think it's not right to, say, well, we'll exclude it anyway. Chickenpox is something we've diagnosed many times. Things like hand, foot, and mouth, a 5-year-old. It's hand, foot, and mouth with vesicles in the mouth, the hands, or the palms. You don't have to go through the monkeypox trauma, and parents get very anxious, and I think that's absolutely inappropriate. Very important always to consider looking for other STIs. They're part of the same picture, absolutely need treatment, and to make sure that the HIV component is very carefully looked at. Currently, it's not a officially notified disease. The minister has agreed that it will be notifiable so that you can measure and manage, but it's not yet gazetted. And we have no treatment drugs. We might have access to one of them, but at the moment there's nothing, and we have no vaccine. And the focus at the moment is on identifying cases, isolating them for 21 days, which I think has many issues, which we'll speak about, and following up contacts so that they can be observed for, or they observe themselves for lesions, which is fraught with many problems and many gaps. So what should...
Sorry, can I ask a quick clinical question? Is it pustules or vesicles?
So they're vesicles. So they're clear.
Okay, and then does it scar, those terrible lesions?
So they can scar.
So it's like a smallpox.
Yeah.
Sorry.
Yes. So I haven't gone through all the differentials, and if you want to learn more about them, so there's a webinar tonight that will focus on the clinical presentation. And in fact, we had one at Mark's Mendelssohn's ID meeting on Friday. But this is going to really focus, just a bit of background, and we're going to look now at the public health response, where the focus will be. So I think we need to recognize that monkeypox can affect anybody. And it's transmitted maybe respiratory, maybe by fomites. The scales, the DNA virus kind of hang around for a very long time. But generally it's skin contact, close contact, skin to skin. So it shouldn't be labeled a sexually transmitted disease. It just happened to, find its way into a community where perhaps close physical contact, is quite common. But it doesn't discriminate. And I think we can talk about it afterwards. When HIV started, it was known as a gay disease and then moved into different communities. So I think that's important. What do we need to do? We ensure that the response tackles stigma and discrimination. I'm going to talk about that. There are many outstanding knowledge gaps. We're using vaccine, we're using drugs. We don't know all the answers about who, what, where, and how, and will it work. And we need to provide high quality guidance, information, and recommendations, despite all the gaps. And there have been some really terrible communications sent out. And we can discuss those a bit further. So low mortality, high morbidity. I think, people have said, well, what's the fuss? Very few people are dying. Well, I think with time that, those numbers might change, but morbidity is considerable and the numbers are growing. So I've mentioned some of the modes of transmission, and that really is important in terms of looking at control methods. Sexual transmission, although the virus is found in the semen, we don't know if that's a mode of transmission. We do know that with many viruses, the semen is a sanctuary site. And even after the acute outbreak, you can get the virus persisting there. We see it with Ebola, for example. We saw it with Zika. Many months after somebody's been infected, they could pass it on through sexual transmission. So that is not known. The other thing we don't know, and this talks very much to what we went through with COVID, so we don't know if asymptomatic people, especially during the incubation period, can pass on the virus. And so if you use diagnosis, identification of cases, isolation as a key method of prevention and reducing transmission, that's going to be a problem, as it has been with COVID. So the current response is to identify cases, confirm the diagnosis, isolate for 21 days, do contact tracing, and introduce appropriate infection prevention and control. But look at the problems with all of those. So people are not coming forward. They may have single lesions. They may not recognize the disease. Access to diagnosis is very limited all over the world. And the lesions look like many others. So identifying and isolating to stop onward transmission is something that may not actually reduce the outbreak at all. Isolation for 21 days, and this is home isolation, I think is quite a challenge. Mental, emotional, practical support is not available for everybody. And I think isolation comes with many issues. Contact tracing, I think, is the most difficult area. So many patients who've been infected don't know who they've had contact with, or they don't want to admit to the contacts, don't want to reveal the names, confidentiality, but for many cases, they don't actually know who those contacts are. So, if you want to stop the outbreak, contact tracing and informing them that they've been in contact with monkeypox, I think is an intervention that's really, very difficult. The viruses can hang around for a long time, so you may find them in the scales, in skin, in bedding, in towels. They're not that difficult to deal with. It's an enveloped virus. You can take some very commonly used disinfectants, clean down. That's not a big issue. So, I think the identification, the isolation, the contact tracing are not going to stop this. And then I think, there's many stories from people who've been infected about the really difficult journey they've had to experience from being concerned about their infection, considering that it might be monkeypox, trying to seek care, getting many incorrect diagnoses from many health providers. For most people, monkeypox is a new disease to recognize. And if you look at some of the clinical differentials, you can see how easy it is to misdiagnose as another sexually transmitted infection, herpes simplex, or another infectious disease. The paucibacillary nature of many, not bacillary, the paucity of lesions in many people infected. There may be in areas that they can't see. I think getting a confirmed diagnosis is difficult. The access to Testing is problematic. Until quite recently, there were in the United States, which has a growing outbreak and good resources, very, very few diagnostics available for diagnosis. And then the poor management. And this man described first his journey, how he was informed that it was positive, that he had to go to many, many health providers. He was turned away from many laboratories, and it was a terrible and very traumatic journey for him. And then I think what's not been recognized is the morbidity, the enormous pain that some patients are experiencing, requiring hospitalization, quite high-level analgesia, and experiencing excruciating proctitis, rectal pain. So what are the treatment drugs available? Well, both the vaccines and the treatment drugs were really developed for smallpox, and have now needed to kind of move to being used for monkeypox with fairly limited data. So tecovirimat is, or TPOX, was approved for smallpox in the United States under what they called the animal rule. They couldn't use smallpox to do the studies. You know, smallpox was eradicated in the 1970s. The virus was only kept, viral cultures with viral samples were only kept in 2 laboratories in the world. And you can't just work with smallpox. It's not something that you would kind of use for testing drugs or vaccines. It's not like that. It's a very high-level dangerous pathogen. So they use smallpox as a sort of surrogate, which I suppose is now, you know, quite a good thing. So tecovirimat was studied using the animal rules. So they used animals with monkeypox, and then they did safety studies in humans, and they did dosage studies in humans. So in retrospect, in what we're dealing with now, you know, it's quite a great benefit. They had planned a randomized controlled trial in the DRC. I'm not sure it was the plan of rolling out tecovirimat in the DRC in any way, but because there was, you know, endemic disease of monkeypox in Africa, they planned an RCT, but that seems to have been shelved. I don't know. And now there's a USA study that's planned. Just remember, it's a different clade. The clinical disease is different. So I'm not sure you can really say that if it works in the United States, it'll work in the DRC or vice versa. So monkeypox was eradicated in the 1970s. The official date was 1979. And it was eradicated because there was a very effective vaccine. There was no animal reservoir. So it's a little different to monkeypox. Patients presented with very obvious clinical signs, and there was an intensive global program to address the problem. The last patient was Ali, who was a cook in Somalia. I think he was in 1976. And sadly, Ali was involved in polio eradication campaigns, and he died of malaria. So the last vaccines were done in most parts of the world, including South Africa in the 1970s. It was done with that horrible sort of pronged instrument. I remember, I can't remember which arm it was, but we received it. But there's been no vaccine since the late 1970s. And most people who had vaccine then would have been protected against monkeypox then, but now there's waning immunity. And waning immunity, people vaccinated in Africa, is probably the reason why, one of the reasons why we're seeing an increase in number of cases. But after the eradication, there were two places that kept smallpox, one in the USSR and one in the United States. All other stocks were destroyed, but the US kept a strategic stockpile of vaccine, and they continue to vaccinate certain people. So some people in labs They also vaccinated people going to conflict in certain areas because it was considered a possible bioweapon. Now we've got some stockpile of vaccine, and here we have monkeypox, for which this vaccine was not developed, but will protect in some way. So there are two vaccines. The old one is, and this is a sort of newer generation of it, is ACAM 4000 made by Sanofi. There's lots and lots of it. That was the major stockpile. But it's made from live vaccinia virus, one of the members of this orthopox virus, and it's replicating. It has some nasty side effects. So it can cause some eye problems, it can cause some skin issues, but most importantly, you can't use it in those with immune suppression. So it's not really suitable for this outbreak, where currently most of the cases are in a population where there's a high HIV prevalence. And you can't use it even in a household where somebody is immunocompromised because it can spread. So it's these big stocks aren't of much use. The better vaccine is something called Genios. This was developed in, I think, the early 2012, 2013. It was also developed for smallpox. It's non-replicating. It is safe. There's been clinical studies on immunogenicity in humans, but we don't know the correlates of protection for monkeypox. So, is it going to be highly infectious? But there's efficacy data from animal studies. So it's now registered. It's made by a relatively small company called Bavarian Nordic, and there just simply aren't enough stocks. So, can newer vaccines be produced? We've learned so much about vaccines through COVID. Are there some different platforms that one can use? So there are two strategies, and this is the difficult part. They started off with post-exposure vaccination, like a ring vaccination, which was a strategy during smallpox. So if somebody's got monkeypox, you identify their close contacts and you vaccinate them, usually within 4 days, in the hope that they will be protected from infection. Well, we know that's a problem. There's delayed diagnosis. There's poor identification of contacts. So, is this going to work to break the chain of transmission? What is the coverage required? Who's the real target group? This is not something that's going to be easy to put in place. The other is to give pre-exposure prophylaxis, identify high-risk groups, vaccinate them before they're exposed, and hope that the disease will be less severe, or maybe you will reduce transmission in that way. But we don't know about what is the coverage required, is there herd immunity, what is the safety, efficacy, and all the groups that might be affected. There are just so many unknowns. But that's the kind of thinking at the moment. So the big problem is shortage. And I think there's been huge uptake by groups who consider themselves at risk. Yesterday, the FDA approved a fractional dose, 1/5 of the dose. Usually it's 2 doses, 4 weeks apart, with immunity only 2 weeks after the second dose. But this is a way of dealing that we've dealt with before for vaccine shortages, but we really don't know if this is going to work adequately. And we don't really have good markers of protection. Big problem is vaccine equity. And that's a scene in the West. But what about Africa? There are absolutely, there hasn't been any talk about vaccine coming to Africa. We know some of the issues around COVID vaccine, late and limited access through many of the structures that were established to try and improve equity during COVID. But to date, monkeypox is very much the science that the world has ignored. And I think there's concern that, it's only being noticed now, that it's moved into the West, there's a growing outbreak, but it's been a problem and a growing problem in Africa for many years. Lots of knowledge gaps, much higher mortality, morbidity, several hundred deaths reported every year, particularly in the last 4 years, and a concern that nothing is going to change. So that's something that we will discuss. And then something I'm going to invite Johan to talk about is communication, misinformation, stigmatization, and discrimination, and how to get correct messages out to risk groups without stigmatizing, to ensure that both health professionals and those affected are equipped with the best possible information to diagnose early, but also to protect themselves. So just to acknowledge some of the staff who've been involved, it's really been a very busy time, and to move on to some of the discussions. So let's start with you, Johan, and some communication messages. Johan has been involved in HIV for many years with Nova, and what to do right, what we've done wrong, and not to make the same mistakes in dealing with monkeypox. So over to you.
Thank you.
And then after Johan is finished, we can speak about equity, about vaccines and countermeasures.
You need some leeway. There we go.
Okay, over to you.
Just those things.
Yeah, that's fine. All the mouse should work. Share that. How's this?
Thank you.
No, thank you.
Prof. Blumberg, thank you for inviting me, and thank you everyone for being here. Good afternoon. Good afternoon to everyone online as well. My name is Johan. I've been working for the Inova Health Institute for many, many years. I'm part of the furniture since 2009. And I don't know if you guys know, so Inova is a non-profit company, but I've been working for the MSM program since 2009, and it's called Health for Men. So I've been writing the communication that's been going out about monkeypox. We started writing stuff around about middle of June. We started writing communication. And as Prof. Blumberg said, it's very, very important that we give people the right communication and that they know what needs to be said. I think what is important, I've literally got 5 slides. I want this really to be very informal, is we need to have clear educational messaging. I think for me, an important thing is we need to remember that looking back, we have the internet now. We have social media now. And we cannot pussyfoot around what's actually going on. We need to give people the facts. We also don't, we've seen it with PrEP as well, where there was so much misinformation about PrEP when we started doing PrEP, pre-exposure prophylaxis. And we need to give people the right communication. They need to know what is going on. So I think clear educational messaging is important. Repeat messaging. You all know how we get bombarded with stuff on a daily basis. And if you don't repeat stuff, if you don't tell people again, people are going to forget. I think Prof. Blumberg has already said a lot of very important things about stigma, about discrimination, and about communication. And I think at the end of the day, we actually really need to help people to make decisions for their own health. They need to have information so they can make the right decision to protect themselves and to protect their community. I think it's always interesting. I speak to people and patients about it on a daily basis. It's funny how doctors and nurses have to speak to people about sex every single day, but doctors and nurses get so uncomfortable when they need to talk about sex. I talk about sex all the time at work, that's what I do. And I think it's so important that we also need to remember what is normal for me is not necessarily normal for someone else. So it's very easy for us to say to someone, you need to stop having sex. But some people may not be able to stop having sex. Just like someone who's injecting drugs may not be able to stop injecting drugs immediately. So we need to think about harm reduction strategies. How are you going to tell a sex worker you need to have less sex if that is the way she brings food onto the table for her kids and for her family? So I think we need to really look at harm reduction approaches to actually reduce stigma. And something that I said to Prof. Lucille before we even started is we're going to look at the messaging, but I think we need to also remember what I said is the fact we have the internet, we have social media. Gays have been stigmatized already. So just give them the facts. They want to know what is going on. And that's why I'm so glad that you talked about the morbidity. You talked about the anorectal pain. You talked about the proctitis. Because, yes, for a lot of people, it is a very mild disease. But you are going to find people who have debilitating symptoms. And I think we need to talk about those things for the targeted populations. And I think what is important is we obviously need to give people ways of communicating with us so that we can link them to testing and link them to care if necessary. So we have to have a generalized messaging. I think, yes, it is important. And as Prof. Blumberg said, HIV started in gay men as well, but it's now, we know, a general population problem, a pandemic. And same thing could happen with monkeypox. But I understand that we need to have different messaging for the general population, and then we need to have targeted messaging for the most affected population. Because obviously it's not going to really be, if you're going to talk about anal pain and rectoanal pain and proctitis, that's something that you'll discuss with the most affected populations. So just to show you guys, these are some of the things that we have done. This is more our initial general media campaigns. The initial thing was just actually, what is monkeypox? And it was asking people's questions about symptoms, how is it transmitted? What do you do if you get it? Most of the things that Prof. Blumberg has already discussed. And then when we got our second case, we brought out more communication. I think the thing here is, it is a bit of a problem because if you look at that shoulder, it could be practically anything. And as we say, that a lot of people would actually think about, is this chickenpox? The big difference with chickenpox, obviously, you can see blisters in all the different phases, whereas with monkeypox, the blisters all look the same. And then this is what we have been doing as well. This is our last communication that actually went out. Monkeypox quick facts. And what we have here is the one on the left is our internal messaging. So that's for Renova Health Institute. And then we have a WhatsApp line for our clinic where people can WhatsApp us if they have any issues, if they think they have monkeypox, they can WhatsApp us. We can organize testing, whereas that is more our yellow dot doctor. So yellow dot doctor is, it's very prevalent. Well, it happens a lot in Joburg. There are doctors in Cape Town as well. So these are doctors that are gay and many have sex with them, MSN friendly. So you can go to these doctors and you can actually talk about sex. They're not going to freak out. So that's communication that goes out to yellow dot doctor. And I think the other important thing, as I said at the end of the day, is we need to keep up with what's going on. We've been, if anything new comes out, we will communicate it with people. This is just what we've been using online. We have got an online booking system for our clinic where there used to be, people would have to be screened, they would have to answer COVID questions before they could make a booking for our clinic. We're now going to change that to monkeypox. So that we know that the guys at monkeypox, they can immediately chat to us. We can try and find out, we can try and do contact tracing, help them with all those kind of things. Yeah, this is pretty much, I don't have a lot of slides. That's pretty much me. I don't know if there are any questions or anything anyone wants clarity on.
I think it's to answer some questions. So what should we be doing as a country? Some really awful communications have gone out. The one was you can get it from raw meat and from touching animals. And then there was a big picture of a T-bone steak, which they'd taken probably from a cookery magazine because it had little carrots and beans on it. So, I mean, that's completely wrong. It's animal related in Central and West Africa, in the forest, and from, these non-human primates and the rodents one finds there. But this was a communication that actually had a Department of Health kind of sticker on it. I don't know if that's, who did it. But that's the sort of messaging that's out there.
I know the Discovery also, there was a lot of people had a lot of issues with Discovery as well, because they brought out communication that was very stigmatizing for gay men and MSM. So I think at the end of the day, people need to understand that, it's important. We're all human beings, and we need to make sure that we give people the right information.
So first of all, there's the right information. Clearly, the T-bone steak one was absolutely wrong. But the health provider information from Discovery had a lot of good facts, and they had huge backlash. If you don't mention the community where it's most commonly being transmitted, surely that's also a problem.
No, absolutely. And I mean, I think that's what I said as well, is how we also need to give people the real, the real facts, what's actually going on. Because gay men will want to know that they could get debilitating anorectal pain. They're going to get severe proctitis. So I think at the end of the day, there's a fine line between how you do it, how you don't do it. But you're absolutely right. We need to mention the groups that are most at risk.
Yeah, you can't get away from it.
No, you can't.
And yet when you do mention them, you are criticized. So what's the answer?
I think the answer is maybe what we need to do is more targeted communication, especially about like the anorectal pain and the proctitis, will be on social media platforms where gay men or MSM would have access. And maybe I don't know if it's if you could actually give someone to talk about monkeypox as someone who's had it. Maybe a gay guy who's had it would also make it more real for people. I think that's another thing we could potentially try and do.
Yeah. So let's hear some comments and questions and ideas.
Yeah, and there are also quite a few comments in the chat that we can potentially bring in. But before we go there, are there any particular questions or comments from anyone here? I had a question about HIV. Is the disease more severe in people with HIV? Do we know?
So I think it's one of the gaps, and we're still learning. But orthopox viruses as a whole depend on cell-mediated immunity to affect a response. So it may well be. But, a person who's HIV infected on antiretrovirals, may not necessarily be the same as someone who's not. Yeah. So I think it's one of the gaps.
Okay.
But CMI is very important for orthopox viruses.
Yes. Hi.
What are the case definition or clinical criteria at the moment for getting a diagnostic test as the NICD?
Yeah. So I'll give you the website. I think it will be included tonight, but it's usually somebody with a rash that's compatible, a vesicular rash that may be compatible, and they've included a couple of symptoms, a recent onset of fever, more the prodrome. We know that some people get the rash first and then the sort of fever, so that doesn't easily apply. But it's really a vesicular rash, or a rash with scabs, or a rash that's, I can't remember the exact one, but I can refer you to the thing. Has to be very sensitive. Case definition must be sensitive. We don't want to miss cases. But really, some good clinical acumen based on, what you learn as a doctor. This is chickenpox. I always call it the calamine sign. Somebody comes in scratching with vesicles and papules and scabs with calamine everywhere. It's chickenpox. It really is. I promise you. Be brave to tell them they've got chickenpox. You'll save a lot of angst and work.
Lee?
So one of the critical parameters in STI epidemiology is the proportion of cases that are asymptomatic. And I don't know if there's been any cases that have been identified as asymptomatic with monkeypox. Do you have a sense of the relative frequency of it?
So, no, I think the issue is that in some patients, there are very few skin lesions. Some have only had one that they've known. They may be in areas that people can't see easily. So they're not actually asymptomatic. They're just not noticing. I know there was a paper submitted, but it's still being reviewed about asymptomatic disease and transmission. But I think the big limitation was, you know, the clinical picture with one or two lesions that you just can't see. Yeah. But that sort of information, there's a gap. We learn every day with these new emerging diseases in new communities. Sure.
Okay, we have a question, online question from Pancho, if you want to unmute and ask your question. And then Peter van Kiersten, you have posted a lot of information in the chat, which is fantastic. But I wondered if you wanted to just comment after that about the misinformation that you've commented on specifically. But we'll first go to Pancho.
Thank you so much, Professor Marianne.
Sorry, Pancho, your sound is not great. I don't know, it might be better if you post a question in the chats.
You hear me now?
No, it's still not great. Okay. Peter, perhaps we can go to you. I don't know if you want to comment. You've put a lot in the chat about some of the different trials and also about misinformation.
Yeah, look, I haven't really been. We're going to get an echo because can you mute on your side?
Yeah.
Okay, is it working better now? Good. Okay, so the obviously this is being picked up. It's actually quite interesting. Misinformation flying around has actually taken two forms. The one has been the kind of minimize the kind of misinformation, but there's been this dramatic uptake of like you can get monkeypox from. I mean, meat was mentioned, but you know, from a toilet seat, from books, from the subway, from all sorts of things. So there's definitely, I think one of the things that has to be tackled in the communication, and I think it was mentioned very, very well, is that there needs to be a two-stage communication strategy, that there's what the general population needs to know, because really a lot of the misinformation has been about what is really a very, very low risk to the general population being inflated. Okay. And then on the other hand, saying like, okay, but within these closely connected networks, and I think that people in the chat have mentioned some other examples of what might potentially be closely connected networks, then the messaging has to be different. And I think it is worth looking at, I think it was a 2017, 2018 paper that in the early stages of the Nigerian outbreak did look at the possibility of sexual transmission there, but it wasn't really investigated much further. And then, you know, so there might be other sexual networks that we should keep an eye out. And I think the STI clinics can be doing their role there besides MSM ones, because, but at the moment, there's a huge amount of misinformation about the susceptibility for the general public.
Okay, so absolutely agree with you, and I'm sure Johan would concur. So we need to be very careful. You know, when we say it's transmitted through direct contact through fomites, but also the respiratory route, people immediately think of COVID and the respiratory route. And it's not a major issue with monkeypox. And it certainly has a very low R0, which is the sort of transmissibility index. So, you know, that's not the route. So it's very easy for people to pick up on that and say, oh, I can get it by being in the same room. So I think,
Pick up on the hysteria, yeah.
yeah.
Yeah, there was, Pancho had the question, he's put in the chat, which he says, are non-MSM men, non-MSM and women avoiding testing? Do you think that they're avoiding testing because they feel that they will then be labelled with the stigma because they're not brave enough? And is it really so uncommon in the general population? Do we think? You talked about underdiagnosis.
So I think underdiagnosis is mainly in the community that's affected at the moment. As things move on, I mean, there have been a couple of children who've had confirmed monkeypox, and I think those are still being followed up. I think one was in a household where there was somebody with monkeypox, so it could have been, probably through fomites and skin shed with virus, I don't know. There've been a couple of women, and I don't think there's been clear information about how that was transmitted. But we know things changed, and that was how it happened with HIV. So, these are early days.
I think we also should remember that MSM can always form a bridging population.
Yes, that's
men who
exactly.
have sex with men may have sex with women as well.
Yeah.
So close skin to skin contact between a man and a woman
Yeah.
could also transmit
Yeah.
monkeypox. But I think you're right, Prof. Right now, we're seeing it in a
Yes.
specific population, but there is a potential that it can spread.
Yeah. The other misinformation is about safe sex. So safe sex to many is like using a condom. But for monkeypox, the lesions, the lesions are, everywhere. The lesions are anogenital area, and a condom's not going to do anything. We don't know that finding the virus in semen actually means that it can be transferred in that way. Yeah. That's unknown at the moment. So, that's sort of taking the same messaging from HIV and putting it into monkeypox is not going to work.
No, it isn't.
Yeah, right.
The one thing we were thinking of looking at, and in fact Mariette, who I think is on the call, I'm not sure if she's still there, was if there is a likely misdiagnosis, either as herpes or as chickenpox, whether we would see an increase in acyclovir prescriptions for people who are not testing. Now, we didn't see that in the public sector because it's very hard to access acyclovir in the public sector. But it would be interesting to look in private sector health insurance, whether, where they may not have tested, but there may be misdiagnosis.
And it's interesting you said this because I was thinking about the asymptomatic viral shedding that you get with herpes and whether you would get this with monkeypox as well. Which we don't know as of yet.
Yeah.
There's another question in the chat just in the last 2 minutes. Ahmed Kalebi, who I think has commented on diagnostics access as well.
Hello.
But I'm muting us because otherwise you'll get an echo.
Okay, so I'll be just summarizing my question. I was wondering, I'm a PhD research student at UCT, but I'm based in Kenya. I'm wondering what the testing capacity is in South Africa right now. And actually, my PhD is about the testing debacle with COVID. And I'm seeing there is not enough effort going on to increase testing and ensure equity. So what is your comment on that, and what is the situation in South Africa?
You're absolutely right. Even in the US, I think it's quite recently there were like 4 testing places you could go to. So I stand corrected on the number, but access to testing is very limited. Hopefully, there will be new, more rapid tests that are developed. For South Africa, it's now being taken up by some of the private laboratories. But yes, it's still limited, and I think in most parts of Africa, it's simply unavailable. So away to go. Yeah, absolutely. I have a question though. You want to answer?
I also have a question.
Yeah. Okay. Then I want to ask Annalise Williamson as the final.
Okay,
question.
here you go.
Yeah.
And we'll ask Annalise and then we'll close.
So, I mean, we know with COVID tests in private, they were very expensive initially,
Yes.
and then they became cheaper.
Yeah.
How much would a monkeypox test? Is it a vesicle that you need to do a PCR
So
test?
the testing is done on a swab on a vesicle, rub it or take some of the vesicle fluid. It's a PCR.
How much is that?
We are not actually charging, I think, the testing at the moment. Maybe we are, can't remember. But I don't know. Some of the private labs have just started to roll it out. So there are new kits. And as you had with COVID, you'll have PCR in 1 or 2 centers. Hopefully, there'll be better access, there'll be more rapid tests, easier tests. But you need controls and you need to make sure that you're doing it accurately. There's nothing worse than poor quality testing. When you say it's monkeypox and it's something else. So one has to be a little careful and make sure that it's good quality tests. You change somebody's life with the result.
No.
It's not a good thing. So I have a question for Annalise Williamson. What about COVID? I think opened up many new possibilities for vaccine rollout and production. What do you see as the way to go for monkeypox vaccines? How easy are they to produce, especially the genius for mass production? What are the issues? Should we be making them in Africa? I mean, this is an African disease. Why are we always, waiting for others to help us?
So I can comment on that. I think we should definitely be making vaccines in Africa, and modified vaccinia Ankara is one of those vaccine platforms that could be used to make other vaccines as well. And it's interesting that Bavarian Nordic have a phase 3 trial going on at the moment, which is a recombinant between MVA, which is the monkeypox vaccine, and RSV. And so one could imagine that if you could actually combine both those diseases, you could vaccinate for RSV, which is a more serious problem or more widespread problem in Africa, and also protect against monkeypox. And I'm actually going to go and visit Bavarian Nordic next month to chat to them and to just explore the possibilities of whether they would be interested in setting up factories in Africa. There's a big drive now from Africa CDC to set up manufacturing in Africa. And I think it's time that we just started looking after ourselves, and that people need to start looking at these things. But I think recombinant vaccines are quite a big thing. There's also an Ebola vaccine based on MVA. It's a combination adeno-MVA, prime boost. So there are vaccines out there that are being looked at. And I think we need to explore these combination vaccines, because it's difficult to imagine that we'll vaccinate the whole continent against monkeypox, given all the other disease problems we have. But we could justify it if we're vaccinating against more than one thing.
Endemic areas in West and Central Africa, where the mortality and morbidity is really significant. Absolutely.
Remains for me to say a huge thank you to Lucille and Johan for being here in person. I think you all need a round of applause for being here in person too, and many thanks as well to our online audience. Thanks so much.
Thanks very much.
Thank you.